Well, welcome back to the second lesson in occlusion for the dental team, specifically talking about the temporomandibular joint. And right now what I'd like to do is take some time to remind you sort of where we are in the exam and treatment planning process. As we're doing the exam, this is, we've talked about our history with our patient, we've done a muscle exam, and this is the joint part of the exam, obviously, so that we can actually have a diagnosis within the functional aspect of our aesthetics, function, structure, and biology, so that we can have a treatment plan that incorporates everything together. So we're looking at joints, specifically so we can diagnose the function, so that we can have a predictable and individualized treatment plan. So as we start to talk about the anatomy of the temporomandibular joint, and yes, I'm going to use the word anatomy even though it scares us sometimes, we got to remember it's really just a ball and socket. And so when we talk about the ball, it is actually what we call the condyle, or the ball that goes up into the socket. And don't forget, the ball is actually connected to the rest of our mandible. So whatever happens to the ball and through here has an effect on the mandible, or where we move our jaw affects the ball. And so again, that's the condyle. And really there's not usually a lot of problems associated with the condyle. The second part of the anatomy that I want to talk about today, and it sort of makes sense, would be the socket of the ball and socket, or what we call the fossa. And really, again, it's just where the ball goes into the socket, and it's basically the bone that is at the base of the skull. So the fossa itself is part of your skull. And really there's also not a lot of problems that we deal with the fossa. It tends to be, the ball and socket tend to be things that we least see problems with unless there's a history of some type of arthritis or bony deformities. But in general, for the sake of this conversation, the ball and socket don't usually create a lot of problems for us. The third component, however, is the disc. And the disc we talk about on a regular basis because it's when things get a little bit crazy right now. Because the disc is really a piece of cartilage that goes in between the ball and the socket. And it's cartilage, meaning it doesn't have any nerves or blood vessels in it. It's just a little squishy piece that goes in between the ball and socket. It's actually what we call biconcave. It's almost like a dumbbell, so it's fat on the back side and fat on the front side. So ideally, when the ball and the socket are where they belong, the disc is in the middle with that skinny part being right in between them. And the disc can create a lot of problems because it is one of the moving parts of the temporomandibular joint. It creates problems oftentimes when it's displaced because it can slide, or it can actually get worn through or perforated. We're going to talk more about that in a little bit. As we talk about the anatomy of the temporomandibular joint, yep, we're going to talk about a muscle here, and yes, we've talked about the lateral pterygoid in the course on muscles, but we have to bring it up again now because as you can see from the photo here, the lateral pterygoid muscle is actually attached to the condyle, and it's also attached, as you can see the top part of it, to the disc. So when we talk about the temporomandibular joint anatomy, we do bring a muscle into play. And again, oftentimes that darn lateral pterygoid, it's sort of the guy that gets all the blame when things go wrong. The lateral pterygoid is oftentimes a component of pain or discomfort or confusion of the temporomandibular joint. But for now, when we talk about anatomy, I just want you to see sort of where it is and how it's related, how it pulls the condyle forward, and it's also attached to that disc. All of this then is surrounded by a capsule. So you can imagine that having the ball and the socket and the disc, it's all incorporated by a capsule in which lives actually some synovial fluid. So it keeps it all inside of there. And the capsule will sometimes create some discomfort really when there's just inflammation inside of there. So if there's any reason, because it's already got fluid in there and it's all walled off in there. So if we bring any extra inflammation in there, we oftentimes find discomfort or sensitivity in the capsular area. But what we're feeling usually when we feel discomfort, just so we can get this straight early on, is that when we're palpating it, it's really just on the lateral or outside pole. So when we talk about actually feeling the sensitivity or discomfort or tenderness of the condyle, it's usually the lateral pole, as you can see in the photo here. So we wish we could feel the whole joint, but really what we're feeling when we think about it three-dimensionally, the condyle is really quite wide, and when we're palpating it, we're really just feeling the outside because the other side is tucked in against our skull. So when the capsule is swollen or there's inflammation, we're really just feeling a teeny tiny part of it right along the outside. But the capsule is a big part of the anatomy that I want to make sure that you're familiar with. Another part that really comes into play, and you'll see this when we talk about the exam, is the posterior ligament, because and it's a posterior ligament of the disc itself. So as you can see, it's attached to the whole disc, and it really just this little ligament that attaches on the back side of the condyle, and it really needs to move with the disc. And so I want you to keep this in mind, this little tiny ligament on the back side of the disc, and we're going to talk about that when we look at function and also our exam in a couple minutes also. And finally, let's take a look at the retrodiscal tissue. And the retrodiscal, meaning behind the disc, is this whole area of tissue that actually does have nerve innervation and blood vessels. And this comes into play when we see sensitivity or discomfort in the joint, because if we impinge upon those blood vessels or those nerves, that's really oftentimes what we're seeing when we have some discomfort in the joint. So again, retrodiscal tissue on the back side of the joint, and when we impinge that, it can create some discomfort, and we'll go into that in a little more detail in a minute as well. And again, this photo here, you can really see the back side, all those blood vessels and nerve endings, and how if we push back on that, certainly things are going to be a little bit tender. So when we look at a healthy joint, again, we've got the ball in the socket with a little piece of cartilage in between, with a ligament that helps hold it in on the back side, a lateral pterygoid muscle that pulls forward on the front side, and some retrodiscal tissue or some nerves and blood vessels on the back side. And that's really all it is. And so I hope that you can see that as things start to move, that, again, we talked about the ball coming out of the socket, that it all works in harmony together. And again, we'll go into function in just a minute with that anyway. But I want you to be able to refer back to this lesson on a regular basis if you need to as a team, because it really just simplifies or breaks down the components of the temporomandibular joint. So that is the anatomy of the temporomandibular joint. Refer to it anytime you want, and I'll see you at the next lesson.